serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clearnet serves as the digital partner for this event, and the focus of today's session is interpretation of ECG. Now, I would like to invite Dr. A.L. Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Penny and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions, including Governing Council Member President and State Secretary of ISA Tamil Nadu State Branch. Over to you, sir. Thank you.
Thank you very much. At the outset, I request our President, Dr. Munian, to offer his presidential address.
Good evening all. I am Dr. K. Munian, President ISA Puthukkottai City Branch. On behalf of ISA City Branch Puthukkottai, I will once again welcome you all the faculties, our academic chairman, and the moderator, and the delegates. Every week we are conducting online webinar in the name of Puthukkottai Bhudhan. Today we are going to conduct second edition of 26th episode of Puthukkottai Bhudhan. Today we are going to talk about the interpretation of ECG changes, ECG in anesthesia. ECG interpretation is crucial in anesthesia, enabling anesthesiologists to assess the cardiac functions and abnormalities, which will guide forward perioperative management in anesthesia. What are the key aspects of in the interpretation in ECG? Heart rate and rhythm. We have to assess the normal sinus rhythm, bradycardia and tachycardia and arrhythmias. Once again, arrhythmias can be divided into tachyarrhythmias and bradyarrhythmias. Today, there are two speakers are going to talk about the arrhythmias. And also, you have to assess the ischemia and infarctions. We have to assess the ST changes and Q waves and TV abnormalities to assess the patient whether he is having ischemia or infarctions. And also ECG electrolyte imbalances. By careful assessing the ECG changes, we can also assess the electrolyte changes like hyperkalemia, hypocalcemia, and hypercalcemia. Cardiac conductions, evaluating PR interval, QRS duration, and QT interval for the signs of conduction abnormalities. ECG changes in anesthesia. Anesthetic agents. Understanding the effects of anesthetic agents on cardiac function and ECG changes such as QT interval prolongations. Surgical stress. Recognize ECG changes during surgical stimulation such as tachycardia and hypertension. Perioperative myocardial ischemia. We can assess the STT changes during perioperative period for the assessment of myocardial ischemia. What are the clinical applications of ECG interpretations? Perioperative evaluation of the ECG using ECG changes to assess the cardiac risk and guide anesthetic planning. Intraoperative monitoring, continuous intraoperative monitoring of ECG to detect the cardiac functions and guide the anesthetic management. Postoperative care, using ECG changes to monitor the cardiac complications and guide our postoperative management. What are the takeaway message? ECG interpretation is essential in anesthesia to assess the cardiac functions and detect abnormalities. Today, our speakers are interested to share their experience with all of us. One more thing, our academic chairman, Dr. A.L. Meenakshi Sundaram, and our respected professors is contesting ISA National President-elect for the year 2025. Kindly support and elect our academic chairman for the post. Thank you all. Thank you, sir.
Thanks, Mr. President. Now I request our Secretary, Dr. Kannan, to offer his report.
Good evening all. I am Dr. Kannan, Secretary, ISA Puthukkottai. Successfully, we are conducting 26th episode of second edition of Puthukkottai Bhudhan today. Today, our topic is interpretation of ECG. I welcome all our eminent speakers to our webinar. Last week, 25th webinar, we have conducted on 9th July. Last week topic was geriatric anesthesia. We have divided the topic into 3 subtopics. First one is post-operative complications in geriatrics. was done by Dr. Aswini Ilango, postgraduate, Velamal Medical College and Research Institute, Madurai, Tamil Nadu. Second subtopic is physiological changes in geriatrics, was done by Dr. R. Lavanya, Associate Professor, Velamal Medical College. And third subtopic, anesthetic consideration of was done by Dr. P. Ramadevi, Associate Professor, Velamal Medical College. Our moderator was Dr. Ganesh Prabhu. Last week, 878 delegates attended our webinar. And one more thing, our academic chairman, Dr. A. Meenakshi Sundaram sir, is going to contest in President National ISA elect. Kindly support him to elect our national president. Thank you. Thank you all.
Thanks, Dr. Kannan, our secretary. Now it is my duty to introduce the faculty to the delegates. But at the beginning, I am very happy. This is our 26th episode. Our target is 52 because we have conducted a webinar on 22-23, 52 successive weekly webinars. Now it is 26th. In Tamil, there is a proverb, crossing off the well. That means even if you cross half the well or 3/4 of the well, you will be fallen into the well. But what I want to convey, this 26th episode, we have well covered and we will not fall in the well. We will cross the well in a very good way. And this is the 26th episode and Bangalore Medical College is participating for the third time. They have a lot of faculties around interested in delivering lectures. And Karnataka state has conducted already 6 lectures in this. And I thank them for their continued enthusiasm in educating the juniors. So the youngest faculty today, it will be Sudeshna Singha. Sudeshna Singha is a second-year resident in Bangalore Medical College, but she has done her undergraduation from Calcutta. So from Calcutta, she has moved to Karnataka. And she is interested in regional anesthesia and critical care. She is interested in reading, not anesthesiology. She is interested in reading novels, stories, everything. So she is interested in reading and she is interested in listening to the music. And now she is not listening to the music. She is listening to the words of her assistant professors and associate professors, or else she is acting as if she is listening to them. So we wish her all the best. And sometimes I used to say this Puthukkottai Bhudhan will become a matrimony column. So this young lady doctor is yet to get married and she is waiting for the suitable spouse. That's what we want to emphasize. And it will be followed by Dr.Madhu KP. Dr. Madhu is an assistant professor of Bangalore Medical College and she is an assistant registrar of Rajiv Gandhi University. So we know how much workload the registrar will have, and she eases the workload of registrar by taking up the post of assistant registrar, and she is the 5th rank holder in Rajiv Gandhi University. See, that is her MD exams. So in my MD exams, I also stand 5th because only 5 people appeared. But it is not like that for her. She is really intelligent and she is doing very good in anesthesiology subject because she is a master trainer in simulation center in Bangalore Medical College. And she used to be the ISA online quiz coordinator. And in the College of Indian Society of Anesthesiology, she has delivered a lecture on how I do the project, how I do a project. So she has more than 10 publications in national and international journals. So she's a faculty in all conferences. If it end up as con, like UACon or ISACon or ICACon or KISACon, wherever it ends with con in anesthesiology, madam will be the speaker and she is interested in educating the youngsters. So she is continuing the job through this because she is following this project, that is this Puthukkottai Bhudhan project. Even though Madhu talks about how do I do the project, This Puthukkottai Bhudhan project was followed by her for 3 months. It is really, she's a warrior, because see, without having the tone of agitation, she could convince me. Every time she calls me, she'll be spoken in a very kind word. And see, continuously, she was following it up, and she has seen to that this Puthukkottai Bhudhan in Bangalore Medical College is participating for the third time. So she is such a powerful warrior. She wants to finish whatever job she is taking. She wants to finish it, and she will not run halfway. And really, madam is a warrior in COVID period. So she is a designated COVID warrior. So she was honored with that award. And see, the fun is ladies are good at economics because they manage the household economics, but she has delivered a lecture on economics of anesthetic agents. That is the best part of it. So she follows economy in everywhere. And as an anesthesiologist, she is interested in airway management, and she has delivered a talk on that. And she has chaired several sessions in many conferences. And she is behaving like a child. And naturally, she is interested in pediatric anesthesiology. I think in addition, she is doing that art. I think mandala art. I don't know what is that mandala art, because I'm not interested in, even in anesthesiology, I find it very difficult to cope up. So this extracurricular activity madam has is she's good at coffee painting. So we used to say bahut bade kalakar. So she's a great kalakar. So she's a great artist. And in addition to that, she's a great anesthesiologist. And we are very happy to have her here to talk about ECG. And madam is continuously educating the juniors in the ECG field. She's interested in that. And to have a moderator to govern these three great lady doctors, we have one hero by name Bhaskara. So he is just like a cine hero, but unfortunately, I think he has joined in anesthesiology, leaving the others to flourish in the cine field. And I know Bhaskara is a satellite launched by India, but he is a satellite for Bangalore Medical College. Now she's very quiet, composed, and he is a member board of studies for PG Clinic. So that is a good thing in Rajiv Gandhi University. And she is a Jiva Raksha trainer. So she's a Jiva Raksha trainer. And see, now India is interested in reducing anesthesia deaths, especially maternal deaths. And once maternal deaths occurred in Bellary, he was appointed as an expert committee member in investigating. So that sort of micromanagement he does. And he has a fellowship in pain management. And he has various publications to his credit. And he is a Copes Award paper presentation in Tamil Nadu. So when Madurai hosted the National Anesthesiology Conference, he has presented a Copes Award paper, and now time has rolled. He has taken the position of associate professor, and he has presented in a Jaipur conference also. So he is a speaker in a national conference, Karnataka state and zonal conference. So he has participated in so many CMEs conducted by the city branches of anesthesiology. So we have a great team in to educate the juniors in the field of ECG, which is very, very important monitoring tool for anesthesiologist. So now I request Dr. Bhaskar sir to take over the session and conduct the anesthesia webinar. Thank you, sir.
So thank you so much, sir, for your kind words. Thank you for your kind introduction, sir. The two major things in anesthesia, what we're supposed to regularly revise and practice is one ABG, another one is the ECG. I'm really very much thankful to the branch of ISF Puthukkottai for organizing this ECG, and which is going to give a premium package of ECG like basic things. Though the ECG, you connect the leads and ECG machine will record it and it give a printout. And presently the ECG report also comes along with the ECG, and it's making we think it's making it very easy for the patients, but it's becoming very difficult for us to answer, because even each patient attenders calls me telling that, sir, it is diagnosed like this. Even though normal ECG, it shows STT elevation, myocardial infarction. That will not give query, it gives straight away as a myocardial infarction. So we frequently were getting calls like this. And one thing is like, see, physician will see the ECG, he'll give, you will recommend some medications. We are not like that because ours is a dynamic ECG which is happening inside the OT. You are supposed to catch what is the main intervene, when to intervene. See, our thing is just because there is an ECG abrasions, ECG changes, you can't go and directly treat the causes. For example, in atrial fibrillation, you definitely can't treat atrial fibrillation. You have to treat the ventricular rate. So main motive of this today's class will be like how the signals are initiated, how these signals are recorded, and how it is processed and it is submitted. One class it will be by our resident Sudeshna. And then coming to the, we have so many other pathologies in ECG. This class is mainly intended for the arrhythmias, both for bradyarrhythmias, which will be dealt by Dr.Madhu KP, and tachyarrhythmias, which is again most commonest what we see in our OT, will be dealt by Dr.Indhu. So I request not waste much time on this, and I'll request our first session by Dr. Sudeshna to start over. It's for you to Sudeshna. Thank you, sir.
Good evening, respected faculties and esteemed guests. Today, I, Dr. Sudeshna, second year anesthesia resident from Bangalore Medical College, would like to take the privilege to thank you everyone for giving me the opportunity to speak in the forum. And the focus of my talk today will be ECG. So electrocardiogram, as we know it, is an age-old diagnostic tool first invented by Dutch physician William Einthoven, and he received Nobel Prize for it in physiology in 1924. By definition, ECG is a graphical representation of the electrical activity of the heart, which precedes and initiates the mechanical contraction, and the same is recorded by applying the electrodes on the skin. And today, the topic of our discussions will include a brief touch upon on the electrophysiology of the heart, the functional anatomy of the conducting pathway, the correlation between the ECG and cardiac cycle, the ECG leads, and the interpretation of ECG. So we have two types of cardiac myocytes in our heart. One is contractile, that causes the mechanical contraction of the heart, and the other one being the pacemaker cells, that is found in the junctional tissue and that generate the rhythm of the heart. So the contractile cardiac myocytes follow the fast action response action potential, and the duration of which is 200 to 300 milliseconds. It has 5 phases. First phase is zero phase, that shows rapid depolarization. Phase 1 shows initial repolarization, that is because of the transient potassium efflux. Phase 2 is a plateau phase, that is caused because of the balanced calcium efflux and influx. Phase 3 is the phase of repolarization, that shows because of potassium efflux, and phase 4 is the resting membrane potential. Pacemaker action potential is also known as slow response action potential, and the duration of it is around 150 milliseconds. It has 3 phases. Phase 0, that corresponds to slow depolarization because of calcium influx. Phase 3, that shows repolarization because of potassium efflux. And phase 4 is spontaneous depolarization, also known as pacemaker potential, because of sodium funny channels. Due to the inherent instability of the resting membrane potential, phase 4 drift upwards, which generates the next action potential without any external stimulus, and is also known as autorhythmicity. And now let us familiarize ourselves with some concepts. First is refractory period. It refers to the duration of time where the action potential cannot trigger a next action potential. It can be absolute, where no stimulus, however strong it is, can trigger any further action potential, which is depicted by the green zone in the curve. Next is relative refractory period. It follows the absolute refractory period, and a larger than normal stimulus is required to trigger the next action potential. It corresponds to the later stages of repolarization, depicted by the yellow zone. Next is effective refractory period. It is the time during which cardiac muscle cannot respond to a new stimuli, and it is a protective mechanism to keep the heart rate in check.
Sudeshna, 1 second. Can you share the screen, ma? It's not visible.
Oh, this one. Is it visible, sir?
Yeah. And can you tilt the screen, please?
Yes. Is it visible now, sir?
Yes, thank you. Please continue.
Next, let us familiarize ourselves with some of the concepts of after depolarizations. These are the abnormal depolarization that occurs before the next action potential arrives, and it can trigger arrhythmia, initiating ectopics. It can be early, that happens during the early phase of repolarization, that is phase 2 and phase 3, and delayed, that happens after the repolarization is complete, that is in phase 4. Now, coming to the conducting pathways, the cardiac action potential is a wave of depolarization that traverses from the sinoatrial node to bilateral atria, then atrioventricular node, and via bundle of His to Purkinje fibers, and following that, the ventricles. Now, coming to a correlation between the ECG and cardiac cycle, ECG wave of P wave represents the atrial depolarization, and it corroborates with the mechanical atrial contraction. PR interval corresponds to the wave of depolarization traveling from atria to atrioventricular node, and it corresponds to the ventricular filling. The QRS complex represents the ventricular depolarization and corroborates with the mechanical event of ventricular systole. Next, ST segment depicts complete ventricular depolarization, and it corresponds to isovolumetric contraction. The T wave shows ventricular repolarization where the diastole starts. Now, coming to leads. Leads are the electrical views are generated from either one in monopolar or two in bipolar electrodes. So in standard 12 lead ECG, there are either limb leads or precordial leads. Limb leads show the heart in a frontal plane, and precordial leads show the heart in a horizontal plane. So basically, electrical impulses originating from the heart is transmitted to the body surface, and electrodes placed on the skin measure the direction of current in waveform in different views. These views are called as leads. And any flow of current towards a positive electrode shows an upward deflection, and any flow of current away from the positive electrodes show a negative deflection. And the height of the ECG wave deflection represents the potential difference between the two electrodes. Now, coming to individual leads, bipolar limb leads form a triangle around the heart that is known as Einthoven triangle, and it consists of lead 1, which helps in the determination of axis, lead 2, which helps in determination of the rhythm, and lead 3, which is used in diagnosis of inferior wall ACS. Now, coming to unipolar limb leads, in this, one electrode is only capable of detecting the electrical potential, known as the exploring electrode, and the other electrode is at zero potential, that is known as an indifferent electrode, which serves as a ground electrode. But the voltage recording across it is too small to be of any clinical use. So, the voltage is augmented by detaching the connection of a particular limb from the central terminal, and this augments the voltage by 50%. So there are 3 augmented unipolar limb leads known as AVL, AVR, and AVF. Some special varieties of leads are posterior leads, right-sided leads, Lewis leads, Fontaine leads. Fontaine and Lewis leads are rarely used. Now, coming to interpretation of ECG. First, we have to identify the patient corroborating with the ECG. Next comes the rate, rhythm, axis, the P wave, the PR interval, QRS complex, ST interval, T wave, U wave, QT interval, and the final diagnosis. The ECG paper constitutes of multiple small boxes, and one large square constitutes of 5 mm width and height boxes, and which is divided into 5 into 5 small squares, each of 1 mm width corresponding to 0.04 seconds of time, and 1 mm height, which is equivalent to 0.1 millivolt of current, and it runs as a standard rate of 25 mm per second. ECG is standardized, where calibration signal is printed in the ECG so that 1 millivolt of potential difference gives a deflection of 10 millimeters in vertical y-axis, and it runs at a rate of 25 mm per second in x-axis. Now coming to rate determination, rate can be regular or in a regular rhythm, rate is calculated by dividing 300 by the number of small boxes between two RR intervals. And if we take into account this number of small squares, 1500 is divided by the number of small boxes between two RR intervals. But if the rate is irregular, then heart rate is obtained by taking the number of QRS's complex in a 6-second strip multiplied by 10. Next comes the rhythm. It can be regular or irregular. Normal sinus rhythm is represented by P wave should be preceding every QRS complex. Now, axis is defined as an electrical position of the heart in the frontal plane, which is the sum total of all the current generated by the myocardium. And out of many methods, one method is quadrant method, where the direction of QRS in lead 1 and AVF is accounted for to determine the axis of the heart. Positive wave means R is larger than S, and a negative wave means S wave is larger than R wave. So if in both lead 1 and AVF both are positive, that shows a normal axis. If in lead 1 it is positive and in AVF it is negative, it is left axis deviation. If it is in lead 1, it is negative, and in lead AVF it is positive, it is right axis deviation, and in both if it is negative, it is northwest axis. Now coming to P wave, it is the first positive deflection and it represents the atrial depolarization. Its normal duration is less than 2.5 small squares, and normal amplitude is less than 2.5 mm in limb leads and less than 1.5 millimeters in precordial leads. Contour can be monophasic in lead 2, biphasic in lead V1. The right side of the biphasic P wave represents right atrial activation. The left part represents left atrial activation. Abnormality includes P mitral and P pulmonale. PR segment is an isoelectric segment between the end of P to the beginning of QRS. PR interval is the interval between the onset of P to the starting of QRS complex, and it reflects the conduction through AV node. The normal duration of it is 120 to 200 milliseconds, that is 3 to small squares. If it is more than 200 milliseconds, it can represent first degree heart block. If it is less than 120 milliseconds, it can represent pre-excitation syndromes like WPW syndrome. Next, coming to Q wave, it's the first negative deflection and it shows left to right depolarization of the interventricular septum. It is pathological when it is more than 1 millimeter wide, more than 2 millimeter deep, and constitutes more than 25% of the QRS complex seen in V1 and V3. R wave is the first upward deflection after P wave, and it represents the early ventricular depolarization. And normally R waves become taller and S becomes smaller as we proceed from V1 to V6. That is called R wave progression, and it is poor in case of left ventricular hypertrophy, COPD, and anteroseptal MI. Coming to QRS complex, it represents the ventricular depolarization, and normally it is 2 to 3 small boxes, that is 80 to 120 milliseconds. Abnormality can lie in duration, morphology, and in voltage. In duration, it is narrow complex QRX if it is less than 100 milliseconds in duration, that shows supraventricular origin. It can be wide if it is more than 120 milliseconds, that shows ventricular origin. There is specific morphology of QRS found in Brugada syndrome, WPW syndrome, which includes a delta wave, and TCA poisoning. And in voltage, normally in limb leads, it is less than 5 millimeters. In precordial leads, it is less than 10 millimeters. It is low voltage QRS complex. She is seen in pericardial effusion, obesity, COPD, hypothyroidism, and electrical alternance is seen in massive pericardial effusion. Left ventricular hypertrophy has many criteria to be determined. Out of many, the most commonly used is Skolov-Linon criteria, which shows S in V1 plus R in V6 should be more than 35 mm. Coming to RVH, out of many formulas, if R wave is more than 7 mm in lead V1, it is diagnostic of right ventricular hypertrophy. There are many special waveforms known as epsilon wave, that is mostly found in arrhythmogenic right ventricular dysplasia, delta wave, that is found in WPW syndrome. Next is the J point. It marks the end of the QRS complex and it's abnormal in hypothermia known as Osborn waves. ST segment is the isoelectric segment that is found from J point to the beginning of T waves. And it is abnormal and elevated in MI, depressed in ischemia. Next, coming to T waves, it represents the ventricular repolarization and it corresponds to the phase 3 of fast response action potential. Normally, the upstroke is slow and the downstroke is rapid. So the normal T wave is asymmetrical. Amplitude being 5 millimeters in limb leads, 10 millimeters in precordial leads. Abnormal T waves are found as in peaked T wave in hyperkalemia, hyperacute T wave in early ST elevated MI or Prince metal angina, inverted T waves normally found in pediatric population or in juvenile population, increased ICP or MI or strain pattern. Biphasic T wave is seen in MI or hypokalemia. Next comes the QT interval. It is the beginning of QRS complex to the end of T wave and it represents complete ventricular activity. Normally, it is 10 to 11 small boxes, that is 400 to 440 milliseconds. And it is affected by the heart rate. So, heart rate should be accounted for to calculate the corrected QT interval that is given by the Bazet formula, that is calculated by taking QT interval in seconds divided by the root over of RR interval in seconds. Prolonged QT interval is found in hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, return of spontaneous circulation post cardiac arrest, increased ICP, or congenital QT prolongation syndromes and drugs. Now coming to TQ segment, that represents the phase 4 of fast action, response action potential and corresponds to electrical diastole. Next is the U wave, that is the last positive deflection of ECG and is best seen in V2 to V3 when heart rate is less than 60. Abnormality can include inverted or prominent U waves that is found in hypokalemia, hypercalcemia, thyrotoxicosis, and digitalis poisoning. And now I would like to end the session with a brief discussion on acute coronary syndrome. ECG changes in acute coronary syndrome can be as follows. In ST elevated MI, within first few hours, there can be hyperacute T waves. In a fully evolved ST elevated MI, within first 24 hours, there can be ST elevation into contiguous leads. There can be pathological Q waves, and there can be symmetric T wave inversion. And in a resolved ST elevated MI, there can be persistent Q waves. In non-ST elevated MI, ST depression plus minus T inversions can be seen in two contiguous leads. The leads where we see the above set changes give us the idea about the walls involved and thus the artery involved in which supplies the said walls. So coming to that, inferior wall involvement is represented in lead 2, 3 and AVF and represents the involvement of right coronary artery. Anterolateral MI is represented in V5 to V6 with lead 1 and AVL showing the involvement of left circumflex artery. Anteroseptal is shown by V1 to V4, shows LAD. Septal involvement is shown by lead V1 to V2, and it can show in the involvement of LAD plus minus RCA or circumflex. An extensive anterior wall can be shown by V1 to V6 with AVL that shows the involvement of left atrial, left LAD artery. These are my references. Thank you.
Thank you, Sudeshna, for your wonderful talk and neat diagrams explaining all the basic of ECG, how the signals are captured, processed, and importance of all the waves and ST segments. And for the participants, we will be answering all the questions at the end of all 3 sessions. Kindly post your questions in the comment section. The speakers will be answering at the end of all 3 sessions. And next session is continuation of the ECG, is bradyarrhythmias by our assistant professor, Dr. Madhu KP. It's over to you, Dr. Madhu KP. Thank you.
Madam, go to slideshow mode.
Yes, sir.
It is on top.
Mm. Good evening, one and all. A warm welcome, greetings from Bangalore Medical College. In continuation with the previous speaker's topic, that is electrophysiology of the heart, and now I'll continue with the following objectives, that is definition and mechanism of dysrhythmias, classification of dysrhythmias, bradyarrhythmias and types in proper, and causes of dysrhythmias and anesthetic considerations and conclusion. Coming to the definition of dysrhythmias, it is an abnormality in the normal physiological rate or rhythm. It may arise from the abnormalities either due to impulse generation or conduction. Now coming to a little bit detail of the dysrhythmia mechanism, where abnormal impulse generation may be due to either enhanced normal automaticity, for example, during adrenergic stimulation, or abnormal automaticity as in ischemia due to activation of ectopic pacemaker. This happens due to either reduced threshold of the action potential or increased slope of phase 4 depolarization, or maybe it is due to triggered activity where abnormal impulse originates from oscillation in the membrane potential that are initiated or triggered by a preceding action potential. So what is an ectopic pacemaker? Any cardiac tissue which is generating a impulse other than the SCA node is an ectopic pacemaker, and any rhythm due to that ectopic pacemaker, we call it as ectopic rhythm. The possible three mechanisms are either due to hypokalemia or localized supersensitivity to catecholamines following an ischemic lesion or a myocardial stretch. In this diagram, you can see the black color is a normal Purkinje rate. Due to activation of an ectopic pacemaker, there is a ectopic beat coming in between, which is shown as a red color. Now coming to the triggered activity. What is this triggered activity? Is once the heart tissue is stimulated once, and there will be production of more than one conducted beats for the one stimulated beat. So two common forms of triggered activity are early after depolarization or delayed after depolarization. Now coming to a little bit detail about early after depolarization, which happens because of net inward currents during phase 3 become larger than the outward current. So you can see in this, there is net inward current is more, so that again depolarization is happening in the phase 3 of the action potential, leading to multifocal ventricular tachycardia. So it can be enhanced by slow heart rate conditions, and it has to be treated with either with pacing or a positive chronotropic drugs. The causes of early after depolarization are hypoxia, hypercapnia, class 1A3 antiarrhythmics, and catecholamines. Now coming to delayed after depolarization, which is most commonly seen during digoxin toxicity, where sodium ATPase is blocked, leading to accumulation of intracellular calcium, which will be moved to sarcoplasmic reticulum. When the calcium inside the sarcoplasmic reticulum is too excess, that will be spontaneously released into the cells, and which will exchange with the sodium calcium current exchanger, where 3 sodiums come in and 1 calcium goes out, resulting in delayed after depolarization. So what are the conditions which causes delayed after depolarization? Is the condition where there is in a fast heart rate and it has to be treated with negative chronotropic drugs. The causes are, as I told you, it is a digoxin toxicity, increased intracellular calcium or sodium, decreased extracellular potassium, myocardial infarction, or reperfusion after ischemia. In this picture, you can see in A and C, there is early after depolarization, which is happening in the phase 2 of the action potential or phase 3 of the action potential. And middle one is delayed after depolarization, where it is happening after phase 4 depolarization. Now we learned about abnormal impulse generation causes. Now coming to the mechanism of abnormal impulse conduction. Main one is re-entry mechanism, where there will be two pathways where the cardiac impulses can be conducted at different velocities. These electrical pathways are embryonic remnants around the AV node, and it will bypass the AV node with normal infranodal tract. In these abnormal tracts, both anterograde and retrograde conduction happens, which are most common cause for premature beats and tachyarrhythmias. Any pharmacological or physiological events that may alter the velocities or the refractive period of this dual pathway results in either initiation or termination of re-entry dysrhythmias. Now coming to ring model around anatomical obstacle or circus movement, where there will be an unidirectional block, as you see in this picture, where picture A shows the normal conduction, and in picture B there will be ischemia and there is blockage, so leading to block in the pathway, electrical block for the electrical pathway. So the current from the normal direction will come and summed up near the block area, and resulting in establishment of reentrant circuit, leading to either sustained ventricular tachycardia or torsades T points. Now coming to the types of dysrhythmias, we can classify them either by the site of abnormality or based on the heart rate. Based on the site of abnormality, we classify them into 5 major types, that is sinus arrhythmia, where the current follows the normal conduction pathway; ectopic rhythms, where the focus is other than SA node; reentrant rhythms, conduction block, where usual pathways are blocked; pre-excitation syndromes, where accessory conduction pathways are activated. Based on heart rate, we can classify them into bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias again further classified into sinus bradycardia and conduction blocks. Now coming to tachyarrhythmias, where there will be narrow complex type and wide complex type, where QRS will be either less than 0.12 seconds or more than that. We classify them into sinus tachycardia, atrial premature contraction, atrial tachycardia, flutter and fibrillation in narrow complex type, and ventricular premature contraction, ventricular tachycardia, fibrillation, and torsades T points in wide complex type. Now we will move on to bradyarrhythmias, where we define the bradyarrhythmia as heart rate less than 60 beats per minute. We can see physiologically in trained athletes or during sleep. The pathological bradycardia is seen in where there is a SNO dysfunction or there is conduction blocks. Most of the bradycardias are benign, but they have the potential to cause hemodynamic compromise or progress to asystole or cardiac arrest. So normally during exercise, the heart rate will increase as per the demand of the person. But in bradycardia, if the body is not, or heart is not able to increase the heart rate, then the patient will have syncope, dizziness, or chest pain based on the severity. So being able to predict when it will occur and understanding the underlying cause is pivotal to early and successful treatment. They are further classified into sinus bradycardia, conduction block, where there can be sinus node block, AV nodal block, which is further classified into first degree, second degree, and third degree heart blocks. And second degree is again classified as Mobitz type 1 and type 2. And last one is bundle branch blocks. Sinus bradycardia is less than heart rate of 60 per minute, but origin of every beat is from the SA node. So when there is a decrease in heart rate, it can lead to decreased cardiac output and poor tissue perfusion. Or if it is severe enough, it can cause altered mental status, dizziness, seizures, angina, heart failure, syncope, up to cardiogenic shock. So the causes are either drug-induced like beta blockers, digitalis, or other antiarrhythmic drugs; acute MI, hypothermia, hypothyroidism, cholestatic jaundice, raised intracranial pressure, chronic degenerative change such as fibrosis in the atrium or sinus node. This is the ECG showing the sinus bradycardia, where you can see the normal morphology. Every P wave is followed by a QRS. With only abnormality is the prolonged RR interval, where the heart rate is around 50. So treatment of sinus bradycardia, if the patient is asymptomatic, nothing is required. the patient is having mild symptoms, the precipitating factor should be found out and it has to be removed. If not responding, then atropine, epinephrine, or dopamine as per ACLS guidelines to be used. If severe, immediate transcutaneous or transvenous spacing to be done. So if not responding, then what will happen? If SA node stops firing, then other secondary pacemakers will take over, like junctional pacemakers or ventricular pacemakers, beating the heart at the rate of 30 to 60 per minute based on what pacemaker has taken up. This is the American Heart Association adult bradycardia algorithm. It says that identify and treat the underlying cause. If not responding, if the patient is having hypertension or altered mental status, signs of shock or ischemic chest discomfort, then go for atropine at the dose of 1 milligram bolus and repeat every 3 to 5 minutes with a maximum of 3 mg. If not responding, then you can go for dopamine infusion of 5 to 20 mics per kg per minute or epinephrine 2 to 10 mics per minute. If that is also not responding, then you should consult a expert and transvenous spacing to be done. Now moving on to the conduction blocks. Conduction block means any obstruction or delay in the flow of electricity along the normal pathway of electrical conduction. So it can occur anywhere between the conduction pathway. So it can further classified into sinus node block or AV node block between the sinus node and the Purkinje fibers or bundle branch blocks. This is a diagram showing ECG showing sinus node block where normally there are normal beats are arising from the SA node with P wave followed by QRS. Sudden there will be no impulse is coming from the SA node. So junctional pacemaker will take over with absent P wave and only QRS complex. This type will account for more than 50% of the indication for placement of pacemaker. And prevalence is 1 in 600 patients aged more than 65-year-old. And there will be always risk of tachybrady syndrome precipitating angina and CCF respectively. Now coming to first degree heart block, where there will be delay in the conduction at the AV node or bundle of this than the usual 1/10 of a second, longer than the usual 1/10 of a second. So every P wave will be followed by a QRS complex, but PR interval is prolonged more than 0.2 seconds, that is more than 1 big box. In this picture, you can see the block where either in the AV node or just below the AV node, and PR interval is prolonged. You can see here it is more than 5 boxes. One more picture showing PR interval of more than 360 milliseconds. And every P wave is followed by QRS complex and the morphology is normal. The causes include inferior myocardial infarction, high vagal tone, status post cardiac surgery, myocarditis, hyperkalemia. It can be medication induced like the drugs I told earlier, sarcoidosis, amyloidosis, Lyme's disease, and infectious mononucleosis, etc. So that is about first degree heart block. Now coming to the second degree heart block, which is further classified into Mobitz type 1 or Wenckebach's type or Mobitz type 2, where not every impulse is able to pass through the AV node into the ventricles. What happens in type 1 is there will be block within the AV node. There will be progressive lengthening of the PR interval until a beat is dropped. Why this beat is dropped is each successive depolarization produces a prolongation in the refractive period of the AV node until the atrial impulse reaches the AV node in the absolute refractive period where conduction is blocked completely. So that time the AV node goes into pause and then again it will recover and the cycle repeats, which is a classical feature of digoxin, and the treatment is, again, if the patient is symptomatic, then we have to treat with atropine. If not responding, then we go for pacing. So this picture shows where is the block in the conduction system and there is a progressive prolongation of PR interval. You can see with the skip and absent QRS complex. So in one more picture showing progressive prolongation like 260 milliseconds, 280, then 320, where only P wave is present with the absent QRS. Again, the cycle is repeating. So now coming to Mobitz type 2, where it has got a high potential to progress to third degree heart block than the type 1. In this, when compared to type 1, there will be progressive prolongation of PR interval with the loss of QRS complex suddenly with the only present P wave. Here, there will not be any prolongation, there will be constant PR interval. So usually these patients will be symptomatic with palpitation and ear syncope. Treatment is transcutaneous or transvenous pacing. So this is the picture showing the block where it causes Mobitz type 2 block. You can see there is a PR interval is constant. There is no prolongation. and only present P wave with an absent QRS complex, which is Obitz type 2. Now coming to the third degree heart block, which is also called complete heart block, with none of the SN or the impulse is getting transmitted into the ventricles. So what happens is ventricles will beat with a slow escape mechanism with a ventricular pacemaker at the rate of 40 to 50. So it can occur as an acute transient phenomenon in case of myocardial infarction, or it may be chronic due to fibrosis around the bundle of his. And it may also be caused by block of both bundle branches, which is also called trifascicular block. So you can see there is no association between the P wave and the QRS. Both are depolarizing at a different rate and the phase. So these are the points at which it can cause third degree AV block. At the his or both the bundle branches are blocked, or the branches, all the three branches of the left bundle and the right bundle is blocked. Again, one more diagram showing a picture showing the third degree heart block. Now coming to the bundle branch blocks, where it can be either due to right bundle branch block or left bundle. In the left bundle, it is again divided into left anterior fascicle block or left posterior fascicle block, or the combination of right bundle branch block or plus hemi blocks, either left anterior or left posterior fascicle block, or block, as I told, a trifascicular block, where all the three will be blocked, leading to third degree heart block. Now coming to the right bundle branch block. Normally V1 and V2 have small R waves and deep S waves, but in right bundle branch block there will be delay in the RV depolarization. So we can see 2 R waves in the ECG with QRS more than 0.12 seconds. So we have RSR dash pattern with deep S waves in the left ventricular leads like V5 and V6. So in some individuals, RBBB will be present in a particular heart rate called critical rate. This is the ECG showing right bundle branch block, where you can see RSR pattern and deep S waves in the V5, V6. And these are the different morphologies of RSR, where you can see first R is left ventricular depolarization followed by right ventricular depolarization. Now coming to left bundle branch block, where delay in the LV depolarization will be present with QRS more than 0.12 seconds. We will see notched R waves in left leads, that is 1 AVL, V5 and V6 with the reciprocal changes in the right ventricular leads. So we have a notched R waves and deep broad S waves in reciprocal leads and notched R waves in the left leads. So in this ECG, you can see we've notched R waves in 1 AVL and V5 and V6, and reciprocal changes with deep S waves in V1 and V2. So this is the comparison between right bundle branch block and left bundle branch block, where everything is common except the leads. So in right bundle branch block, we see for V1 and V2. In left bundle branch block, we see for 1 AVL and V5 and V6, and the reciprocal changes in the leads opposite to each other. Now coming to the hemi blocks, which applies to only the left bundle branch, and the septal branch is not concerning. Major effect is axis deviation. So left anterior fascicle hemi block, where left anterior fascicle lies superiorly and laterally. So what happens is, if this is blocked, though the entire current flows through the left posterior in the direction of inferior to superior direction from right to left. So there will be left axis deviation, and QRS is negative in AVF and lead 2 and positive in lead 1. Now coming to left posterior fascicle block, where the posterior fascicle is blocked, so entire current passes through the left anterior fascicle in the from superior to inferior direction and from left to right. So there will be right axis deviation, and so QRS is negative in lead 1 and positive in AVF, which will be normally negative. So that will say that there is right axis deviation. So how to easily remember is, there will be in bifascicular block, there will be RBBB, left axis deviation in left anterior hemi block, and right axis deviation in left posterior hemi block. So this is the picture showing the RBBB with left anterior hemi block with left axis deviation and RBBB with right axis deviation in left posterior hemiblock. So heart block management, first degree heart block does not require any treatment. Second degree AV block, pacing may be required if bradycardia is severe or causes hemodynamic instability. If there is third degree AV block, then pacing is usually required because junctional or ventricular rhythm cannot meet up the demand of the person. Now that is about the bradyarrhythmias. Now coming to the anesthetic considerations, why these dysrhythmias are important for an anesthetist. So the ASS standard monitoring mandates ECG monitoring for all the patients undergoing surgery and anesthesia. We usually monitor lead 2 and V5 for arrhythmia detection and diagnosis before the appearance of physical signs. So once we diagnose, it is crucial to evaluate the patient's response to altered rhythm and rate and the type of requirement treated. Correction of contributing cause should be done first before the final treatment. So what are the causes of this dysrhythmias? It can be either due to pre-existing heart disease like MI, hypertrophy, or myopathic dilatation, fibrosis, or transient ischemia. Influences may be due to heart itself like transient ischemia, or due to systemic causes like hypoxia, acidosis, acid-base balance, electrolyte imbalance, and electrolyte imbalance, or toxicity because of antiarrhythmic drugs themselves, or autonomic tone is increased or decreased, or endogenous catecholamines can be the cause of dysrhythmias. For an anesthetist, the pain, intraoperative pain can initiate a dysrhythmia, or old age people are prone for dysrhythmias. Lighter planes of anesthesia or mechanical irritation due to CVP insertion or ICD insertion, laryngoscopy and intubation, and anesthetic drugs like inhalational agents, especially halothane or catecholamines, ketamine, regional or local anesthetics when we give either central neuraxial blocks, which causes sympathectomy with parasympathetic dominance, or other drugs like atropine, epinephrine, quinidine, digital toxicity are the causes. Or it can be due to surgical causes, that is traction on intestines, neurosurgical causes, cardiac compression while cardiac surgeries, or CNS disorders like subarachnoid hemorrhage, or location of surgery like dental surgeries where it can initiate a junctional rhythm by stimulation of fifth cranial nerve. To continue with the causes, that it can be due to endocrinal reasons like pheochromocytoma, thyrotoxicosis, hypothyroidism, Conn's syndrome, diabetes mellitus, leading to DKA, diabetic autonomic neuropathy, and hypoglycemia. Or the major ones are cardiac reflexes. I don't go into the detail of each reflexes. These are the cardiac reflexes which can initiate dysrhythmias like Mary's reflex, Bainbridge reflex, Cushing's, oculocardiac, Wiesel-Jarisch, or Brewer-Locard reflexes. Most of them will cause bradycardia. So removal of the stimulus will most of the times will revert back to normal rhythm, or treatment may be required sometimes. So to easily remember, we can classify them into 5Hs and 5Ts, as you know: hypokalemia, hypoxia, HIN disturbance, and electrolyte disturbance and hypothermia, toxins, drugs, tamponade, tension pneumothorax, thrombosis, and trauma are the 5Hs and 5Ts. When I was going through the literature, I came across this 7th National Audit Project by Royal College of Anesthetists, where they examined perioperative cardiac arrest for 1 year. So what they found is severe bradycardia with heart rate less than 30 minutes was uncommon. Whatever bradycardia was there was mainly due to laryngoscopy, which was occurring in 1 in 180 laparoscopic cases. So the bradycardia progress into cardiac arrest was also rare, which happened mainly during gynecological laparoscopic procedures. But the bradycardia associated cardiac arrest, the recovery to hospital discharge was 74%, whereas it was 37% in non-bradycardia associated cardiac arrest. So what they reported was it was mainly associated with insufflation of pneumoperitoneum, which was the common cause. So they recommend early recognition of bradycardia, deflation of pneumoperitoneum, and atropine as the key interventions. And they also reported that arrhythmias are less well tolerated by patients with underlying heart disease. In a healthy heart, we can tolerate up to 150 beats per minute also is well tolerated, whereas 100 to 150, it can cause hemodynamic compromise in a pre-existing heart disease patients. So current resuscitation guidelines for perioperative arrhythmia recommend treating arrhythmia when there is a compromise or risk of compromise, correction of reversible cause, optimizing oxygenation, ventilation, and circulating volume, and correcting electrolyte abnormalities. Severe bradycardia will usually respond to correcting the underlying cause like anticholinergic drugs. If not responding, then we have to use adrenaline in small bolus. If not responding, again, we can go for isoprenaline, adrenaline infusion, or pacing may be required. So to summarize the management, first confirm the reading, rule out the monitor error, call for help, scan the patient, surgical field, anesthetics what we are administering, and monitor for second and third degree heart blocks which are dangerous. Assess the overall patient condition, assure optimum PaO2, PaCO2, acid-base balance, electrolytes, and temperature. Consider other causes and address them. Like if the surgery is the problem, then tell the surgeon to stop the surgery and remove the stimulus. Give IV fluids if it is because of hypotension, or leg up or trendline block position to optimize the preload or venous return. Meanwhile, you manage the airway and ventilation. Consider reversal agents like atropine, epinephrine for unstable bradycardia, or pacing if severe or persistent. To summarize the heart blocks, if it is first degree, there will be prolonged PR interval. No treatment is required in most of the patients. Second degree, type 1, there will be prolonged PR interval, then drop T wave. So if not symptomatic, then no treatment is required. If symptomatic, bradycardia management, as I told earlier, is required. In type 2, there will be drop T wave without PR prolongation. So most of the patients require pacemaker. In third degree heart block, there is no association between the P and the QRS. Pacemaker is the treatment of choice. So to conclude my talk, normal heart can tolerate wide variation in the heart rate. Arrhythmias in a diseased heart can lead to hemodynamic instability and cardiac and other end organ ischemia, CCF, or even death. So clinical significance for us is their effect on the vital organs and potential deterioration into a life-threatening rhythm, which is difficult to manage thereafter. So timely diagnosis and intervention, if required, will decrease the risk of morbidity and mortality of the patient. So these are my references. Thank you.
Thank you, Dr. Madhu KP, for your wonderful talk on bradyarrhythmias. Actually, these any type of arrhythmias are better learnt in workshops. It will be for a day full actually. But Dr. Madhu KP has made it more simplified, and she proved that this can be learned even with online classes also. And most of the tables and diagrams are very catchy, and even I could see Dr. Munian sir taking the pictures of the diagrams, and even other participants can take it as a screenshot of these things, and Madhu KP will also share the PPTs in which are required also. Our next talk is on tachyarrhythmias by Dr. Bindu. It's over to you, Dr. Madam.
Is my screen seen, sir?
Yeah, you can go ahead, Dr. Bindu.
Thank you, sir. So good evening to all. Warm greetings from Bangalore Medical College and Research Institute. I thank Dr. Meenakshi Sundaram sir for giving me this opportunity today, and let's quickly start on tachyarrhythmias. I'll start with a case scenario. Here is a 65 years old male patient who is posted for knee replacement surgery under subarachnoid block. He is a known hypertensive on medication. His blood pressure is under control, but he is mildly anxious regarding surgery. In the intraoperative period, his heart rate increased from 80 beats per minute to 120 beats per minute, but blood pressure remained stable. He did not have any other signs of distress like pain or breathlessness. The anesthesia team at this moment decided to get a 12-lead ECG done to assess any cardiac abnormalities, and also they sent blood test for checking if there is any electrolyte imbalance. Meanwhile, they decided to sedate the patient with IV midazolam, and they were planning to consider beta blockers if tachycardia persisted. So when they got the 12-lead ECG, so this was the ECG that was seen, and what is showing. So we know how to read the ECG. So here what we can see is a normal and constant P wave morphology, which is preceding every normal QRS complex. The PR interval is normal here, and every QRS complex is followed by T wave. The RR intervals are normal, regular, So the rhythm is regular and it is a sinus beat seen throughout the leads in this 12-lead ECG. So whatever I said is being displayed there, and what would be the diagnosis now? So it is sinus tachycardia. So in this patient with this 12-lead ECG, we can make out that it is sinus tachycardia, and this got settled with sedation of the patient with IV midazolam, because I said that he was anxious regarding surgery in the preoperative period. This is another ECG of sinus tachycardia where we can see these P waves which are hidden with the T waves of the previous sinus beat, which is called as camel hump appearance. So when do we call it as sinus tachycardia, and when we have to consider it as tachyarrhythmia? So sinus tachycardia is a fast sinus rhythm with the heart rate more than 100 beats per minute. And tachyarrhythmias are also the rapid heart rates where the heart rate is more than 100 beats per minute, but the rhythm here may or may not be regular. So these tachyarrhythmias are classified depending on the important three factors, that is the origin of these electrical impulses. They can be supraventricular or ventricular. Second factor is the width of QRS complex on ECG that determines the type of tachyarrhythmia that we have to handle with. The third is whether these electrical impulses are getting traversed through the atrioventricular node to enter into the ventricles. Based on these factors, tachyarrhythmias are categorized into three groups: atrial tachyarrhythmias, junctional tachyarrhythmias, and ventricular tachyarrhythmias. Here, atrial and junctional tachyarrhythmias are together called as supraventricular tachyarrhythmias. So coming to atrial tachyarrhythmias, it includes atrial flutter, fibrillation, premature atrial contractions, atrial tachycardia, which can be single focus or multifocal atrial tachycardia. Coming to the junctional tachyarrhythmias, it can be atrioventricular nodal reentrant tachycardia or atrioventricular reinforcing tachycardia, junctional tachycardia, or pre-excitation syndromes like WPW syndrome. Then ventricular tachyarrhythmias would include premature ventricular complexes, ventricular tachycardia, and ventricular fibrillation. Before we go into the ECG interpretation of these tachyarrhythmias, we should know something about another type of arrhythmia which shows variations in heart rate during different phases of respiratory cycle. We all know that it is a normal physiological phenomenon, that is sinus arrhythmia, which is most commonly seen in young healthy individuals. So this incidence of sinus arrhythmia would decrease with age, probably due to decrease in the carotid sinus distensibility and the baroreceptor reflex sensitivity. So let us see what happens with the different phases of respiratory cycle. During inspiration, we all know there will be decrease in intrathoracic pressure, which in turn increases venous return, hence stimulating Bainbridge reflex, thus involving increased sympathetic activity causing tachycardia. On the other hand, there will be increase in lung volume, which would stimulate the stretch receptors in lungs, which causes the vagal afferent impulses to lead to inhibition of vasodilator areas, leading to increased heart rate. The mechanism opposite to this will be seen during expiration, which is associated with increase in intrathoracic pressure that causes decreased venous return and no further stimulation of Bainbridge reflex. And also the lung volume comes down with the no further stimulation of the stretch receptors in lungs. Thereby, the parasympathetic activity becomes predominant, leading to bradycardia or decrease in heart rate. So on seeing ECG in sinus arrhythmia, there will be variation in RR intervals, which can lengthen or shorten corresponding to the different phases of respiratory cycle. The P wave morphology will be normal and constant throughout, and the PR interval is constant. So this is the ECG of sinus arrhythmia. So these blue lines that are seen here indicate prolonged RR interval during expiration. And these are the red arrows which represent shortened RR interval that is seen during inspiration. So the RR interval is inversely proportionate to the heart rate is what we need to concentrate here. So the heart rate in sinus arrhythmia increases with inspiration and decreases with expiration. So now let us go into SVTs. These are the tachyarrhythmias that occur because of the impulses which are arising above the level of bundle of His. So it is supraventricular, which can be regular or irregular in nature. They are mainly caused by reentrant phenomenon or automaticity at or above the atrioventricular node. So most common mechanism is reentrant phenomenon. When we think of this mechanism, we have to differentiate between the two important tachyarrhythmias, that is AV-NRT and AVRT. As seen in the picture, in AV-NRT, there is functional circuit which is causing the reentrant loop. That means the impulse is getting circulated, forming a loop at the level of atrioventricular node. And here, slow and the fast conduction pathways are involved. Whereas in case of AVRT, there is an accessory pathway other than the normal conduction system involving AV node, which communicates between atria and ventricle to carry impulses bypassing the AV node checkpoint. So here is the loop, the reentrant loop that is formed, and this is considered as the anatomical circuit in AVRT. So here is a video which represents SVT. These SVTs are paroxysmal in nature as they appear suddenly and they disappear spontaneously. The ventricles are filling inadequately and there is decreased oxygenation to the brain, wherein the patients present with symptoms like palpitations, lightheadedness, dizziness, shortness of breath, sweating, and fainting. So these SVTs mainly involve atrioventricular nodal reentrant tachycardia, atrioventricular reciprocating tachycardia, atrial tachycardia, atrial flutter, fibrillation, or multifocal atrial tachycardias. In AV-NRT, as I was saying, there will be a reentrant circuit that is formed involving slow conduction and fast conduction pathway. Impulses coming from the atria travel through the slow conduction pathway initially, and then they go back into the fast conduction pathway in a retrograde fashion, creating a complete loop. And finally, this perpetuating loop leads to faster heart rate before these impulses enter into the ventricles leaving AV node. So thereby, in case of AV-NRT, the heart rate will be faster at the rate of around 150 to 250 beats per minute. Most of the situations, the P waves will be absent, they are not found preceding the QRS complex. These kind of AV-NRT arrhythmias are most commonly seen in adult individuals. When we come to AVRT, I said there will be an accessory pathway communicating between atria and ventricles. So the impulses from atria are bypassed through these accessory pathways, leading to early ventricular depolarization. Thereby, the PR interval here will be smaller, less than 120 milliseconds. And there is a small slurred upstroke of R wave in the beginning of QRS complex, making the QRS complex appear wide. So this mainly will be seen in association of AVRT with pre-excitation syndromes like WPW syndrome. Here also the heart rate will be at the rate of around 150 to 250 beats per minute. In case of AVRT, when the reentrant loop is getting formed, the impulses can actually traverse in two different directions. If the impulse is moving across the AV node down towards the ventricles and then it is moving in an opposite direction across the accessory pathway, then that kind of loop is known as orthodromic AVRT, which is more commonly seen than the other directional movement of the impulses, that is antidromic AVRT. Atrial tachycardia, as the name suggests, here the electrical impulses are produced from different foci of atria other than the sinoatrial node. So here there are P waves seen preceding every QRS complex, but the morphology of P waves will be abnormal. And the heart rate here is around 100 to 200 beats per minute. This is most commonly seen in pediatric age group, especially in children associated with congenital heart diseases, or may be seen post-cardiac surgery. In most of these SVTs, as I said, they are paroxysmal in nature. On examination or when we take an ECG, it might appear normal. And there may be misdiagnosed as anxiety attacks or panic attacks in such individuals. And this needs a continuous monitoring and evaluation using Holter monitors. These are some of the underlying causes which would lead to supraventricular tachycardias, and also the important common triggering factors should be kept in mind. Avoiding these triggering factors causing SVT, using medications to control the rate mainly, and also by different vehicle maneuvers would help in treating these supraventricular tachycardias. If not, then cardioversion and radiofrequency ablation would be the treatment of choice. Before entering into the ECG interpretation of these SVTs, we also should know what all would be the abnormal P-wave morphologies that we come across in the ECG of these tachyarrhythmias. So here is the picture which shows the impulse that is being originating from the upper part of the AV node. Even if the impulses are arising anywhere above the level of this AV node in the atria, then also the same morphological changes in P-wave are expected. So what happens when the impulse is originating from the upper segment? The direction of conduction of this impulse to the atria will be in the direction opposite to what we normally see in the normal conduction mechanism, leading to atrial depolarization. Later, the same impulse gets conducted to the ventricles through the bundle of his Purkinje fibers, leading to ventricular depolarization. So as the direction of conduction of impulse is opposite direction to the normal mechanism of conduction, we see inverted P waves preceding the QRS complex in case of upper junctional rhythms. What happens in mid-junctional rhythm? Here the impulses are getting originated from the middle part of the atrioventricular node, and these impulses are simultaneously getting conducted to the atria and the ventricles, causing their depolarization. So here, as it is happening at the same time, we will not see a distinct P wave preceding QRS complex, as it is hidden in the QRS complex, and the QRS complexes would appear normal. This is mid-junctional rhythm. In case of lower junctional rhythm, the impulses are originating from the lower part of the atrioventricular node, so more closer to the ventricles. So the ventricles are getting depolarized first as the impulse is getting conducted to the ventricles, and then the impulse is going towards the atria in an opposite direction. So what we expect here we see P waves seen following the QRS complex, and because the direction of impulse conduction is in opposite way, these P waves will be inverted. So such kind of P waves are termed as retrograde inverted P waves, which are seen in case of lower junctional rhythm. Coming to AV-NRT, so we can see here in lead 1, 2 and lead 3, P waves are not seen preceding the QRS complexes. The QRS complexes are narrow, and we can see a small notch following QRS complex in V1 and V2. So in case of AV-NRT, these P waves might be hidden with the QRS complex, or sometimes they may just seem to be appearing following QRS complex. And these kind of P waves, retrograde P waves in AV-NRT, are termed as pseudo R' waves. So here the RR intervals are regular. So as I told you, AV-NRT, the rhythm can be regular or irregular, and the rate is around 150 beats per minute. So it is the same, the expanded version of the ECG of AV-NRT that is shown here. In AV-RT, the rate is usually 200 to 300 beats per minute. And here also we see retrograde P waves, that is after the QRS complex. And here the important thing in the ECG to differentiate between AV-NRT and AV-RT is the RP interval. In these tachyarrhythmias, we are seeing retrograde P waves. That is why we are considering RP interval to differentiate between the two. In AV-RT, these retrograde P waves appear distinctly clearly after the QRS complex, and therefore they have longer RP intervals, which is more than 70 milliseconds, whereas in case of AV-NRT, the RP interval will be smaller. Otherwise, the other findings of ECG will be similar to AV-NRT in this also. So this is the ECG of AV-RT. So here we can see a clear retrograde P wave following the narrow QRS complex. So retrograde P waves QRS complexes are narrow here. So distinct RP interval is made out. The heart rate in this ECG is around 200 beats per minute. So the important distinguishing features between AVNRT and AVRT, as I was saying, with regard to the mechanism, so in AVNRT, it is the reentrant mechanism within the atrioventricular node. In AVRT, it is completely involving two pathways. One is the normal conduction pathway, the other is the accessory pathway. In ECG, it is mainly the pseudo R- wave seen in the precordial leads in AVNRT with short RP interval. And in AVRT, the distinct retrograde P waves are seen and there are longer RP intervals. Coming to the treatment, both these are supraventricular tachycardias where impulses are forming a reentrant phenomenon. So both of them would respond to vagal maneuvers and medications like intravenous adenosine. If persistent, then cardioversion or radiofrequency ablation will be the treatment. Then junctional or nodal rhythms, I already explained about the abnormal P wave morphology. It's again the same. In upper nodal rhythm, it is inverted P wave preceding QRS complex. In the mid nodal rhythm, absent P waves as they are hidden in the QRS complex. Lower nodal rhythm, so here we are seeing retrograde inverted P waves. Why we are knowing this? Because we have to know what is happening in the junctional tachycardia and how to differentiate them from the reentrant rhythms. So in junctional tachycardia, the main mechanism here is the automaticity that is within the atrioventricular node. The heart rate will be more than 100 beats per minute, most commonly seen in younger individuals and also in the post-operative period following cardiac surgeries. So here is the junctional tachycardia where narrow QRS complexes are seen, and in the highlighted zone we can see clear P waves which are inverted preceding narrow QRS complexes. So inverted P waves preceding QRS complex means probably it will be the junctional rhythm which is arising from the upper AV node. Even these junctional rhythms, while looking at the ECG, might be confusing with AVRT and AVNRT. So how do we differentiate between these junctional rhythms and the reentrant rhythms? So we know the junctional tachycardia, as I said, it is because of automaticity seen within the AVN, whereas in case of AVRT or AVNRT, it is the reentrant mechanism. Otherwise, the P waves morphology will be almost similar in junctional tachycardia and the reentrant rhythms. Narrow QRS complexes are seen in both. The main differentiating feature is that junctional tachycardias, because the automaticity is within the AV node, these rhythms will not respond to vagal maneuvers and they need medications that are helping us in controlling the heart rate like calcium channel blockers, beta blockers, or cardioversion or radiofrequency ablation. Whereas in case of reentrant tachycardias or tachyarrhythmias, they will be responding to vagal maneuvers than junctional tachycardias. Atrial tachycardia, I had already told you there are ectopic atrial foci which are giving rise to these electrical impulses other than sinoatrial node, leading to fast atrial rate more than 100 beats per minute. And here P waves are always present preceding the QRS complex, but the morphology would be different depending on the site of origin of the electrical impulses. The QRS complexes are normal and the PR interval will be normal in atrial tachycardias. So here is the narrow complex tachycardia. Here it is clearly seen in lead 2-3 AVF that there is inverted P wave preceding the QRS complex, which is more suggestive of atrial tachycardia than the reentrant phenomenon. Coming to the atrial flutter and fibrillations, atrial flutter, it is caused by an impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. You can see that in the video, most commonly seen in the right atrium, forming a reentrant pathway. So every time a loop is completed, that will give rise to an atrial contraction. So the atrial rate in atrial flutter will be regular and rapid between 250 to 400 beats per minute. But all these impulses might not get transmitted to the ventricles, which is because of the refractory property of atrioventricular node. So for example, if there are 3 atrial contractions, then only one among them would be conducted across the atrioventricular node to ventricles, leading to 3:1 pattern of atrial flutter. So on an ECG, when we see, there will be absent P waves. Instead, we can see flutter waves. And this gives rise to a sawtooth appearance. And the ventricular rate will be slow and usually regular. Coming to atrial fibrillation, here multiple bizarre impulses are initiated from many ectopic foci in the atria. And most commonly, these ectopic impulses are seen around the root of pulmonary veins. These unsynchronized chaotic electrical signals will be causing the atria to quiver or fibrillate rather than contracting. So the atrial rate in case of atrial fibrillation are very high, and most of the impulses, all the impulses would not be again getting conducted to the ventricles because of the refractory property of AV node. And the ventricular rate in case of atrial fibrillation would also be irregular. On ECG, what we see, absent P waves or fibrillating waves with irregular QRS complexes. So atrial flutter. So as I told you, there are sawtooth appearance of P waves seen between the R waves. Here RR interval is irregular, and there is variation of the atrial flutter pattern between 2:1 to 4:1 pattern here. The QRS complexes are narrow, RR interval being irregular. So when this kind of ECG is seen, Dr. Sudeshna had already told you if there is irregular rhythm, then we need to calculate the rate in a different manner. So here atrial rate has to be calculated by counting number of small squares between two P waves. So P to P interval always would tell us about the atrial rate, and RR interval would tell us about the ventricular rate. In this picture, there are 6 small squares between two P waves. So we have to divide these number of small squares from 1500 to get the atrial rate. If we have to calculate the ventricular rate, then we need to count number of R waves in 15 large squares, which is equivalent to 3 seconds. Or you can count it to 30 large squares, that would be equivalent to 6 seconds. If you are counting it for 15 large squares, as seen in this picture, it is 5 R waves. Multiply it by 20 seconds, that will give the rate per minute. So here there are 5 R waves in 15 large squares into 20, then the ventricular rate is 100 beats per minute. So atrial fibrillation. So here P waves are absent, narrow QRS complexes are seen, RR intervals are varying, so irregular rhythm is found, suggestive of atrial fibrillation. Again here, to know the rate, we have taken into consideration number of R waves in 15 large squares and multiply it by 20. So the rate here is around 140 beats per minute. Then ventricular rhythms. So these ventricular rhythms are most dangerous and lethal rhythms. Ventricular tachycardia is caused by single strong firing circuit in one of the ventricles. This usually occurs due to structural abnormalities like scarring due to old ischemia or any abnormal myocardial fibers that are there in the ventricles. Impulses originated in these ventricles produce ventricular premature contractions that are regular and fast, ranging from 100 to 250 beats per minute. On ECG, these VTAC is characterized by wide, bizarre-looking QRS complexes with absent P waves. VTAC can last for shorter intervals, less than 30 seconds, called non-sustainable VTAC, and usually they will not cause any complications. But if it is a sustained VTAC lasting for more than 30 seconds, it is more lethal and needs immediate treatment to prevent further cardiac arrest. Ventricular fibrillation is caused by multiple weak signals originating from many ectopic sites in the ventricles, and these unsynchronized chaotic electrical signals would cause the ventricles to fibrillate instead of contracting. During ventricular fibrillation, the heart can pump very little or no blood from it, and ventricular fibrillation can quickly lead to cardiac arrest. On ECG, we see irregular random waveforms of varying amplitude without clear differentiation of P wave, QRS complex, or the T waves. The amplitude of ventricular fibrillating waves, as time passes, the amplitude decreases from the coarse ventricular fibrillation to fine VFib, finally ending with an asystole. So this is ventricular tachycardia. You can see the video showing the mechanism involved in it. There are absent P waves. QRS complexes are broader and they are monomorphic in nature, regular, and the rate is around 250 beats per minute. This is ventricular fibrillation. Can see the multiple foci of the impulses arising from the ventricles, causing the ventricles to quiver instead of contracting. This is showing a bizarre waveform where we cannot differentiate the waves at all. So this is ventricular fibrillation. Torsade D pointus, it is associated with prolongation of ventricular repolarization, and it is characterized by polymorphic QRS complexes twisting around the isoelectric line, leading to R-on-T phenomenon. So the pattern of torsade D pointus seen on ECG. Now let us have a few words about the pre-excitation syndrome. As I already told you, this is again the involvement of accessory pathway in it. So most commonly what we see is WPW syndrome, which involves a bundle of Kent as the accessory pathway. It can be right or left-sided accessory pathway involved in it. Accordingly, there are two types of WPW syndromes. The other is the Lowen-Ganong-Levine syndrome, which involves James fibers as the accessory fibers carrying the electrical impulses. So two types of W syndrome. Type A mainly involves the accessory pathway on the left side, showing delta waves being positive in the precordial leads. And type B involves the right-sided accessory pathway, representing negative delta waves in precordial leads, mainly V1 and V2. Most of the situations, these syndromes are associated with AVRT or atrial fibrillation. So LGL syndrome, the accessory pathway is James fibers. Here the impulses passing through these fibers enter into the normal conduction pathway at the level of bundle of His. So no delta waves are seen here, and the QRS complexes are normal. So premature beats. These premature beats also can lead to tachycardias and tachyarrhythmias, probably due to re-entrant circuit that is formed. So we have to know the sites of development of these premature beats. So these premature beats can arise from any site in the heart other than sinoatrial node. Again, they can be supraventricular and ventricular. So in this picture, we can see there are two sinus beats. Following that, there is an abnormal beat seen, and there is a delay in RR interval, and again the sinus beat has started again. So this abnormal beat that is seen in between the two sinus beats is the premature beat. So here, when we compare the P wave morphology with the sinus beat, it appears to be different compared to the normal P waves, and the pause that is there, or the prolonged RR interval between the premature beat and the next sinus beat, is called as compensatory pause. The pause here compensates for the early occurrence of premature beat. So why this compensation is happening? If the premature beat is arising from the atrium, then this will be disturbing the normal conduction mechanism of the sinoatrial node. So the sinoatrial node gets disturbed because of a premature beat, and it has to reset its rhythm again. So this is why there is a compensation. Whereas in case of ventricular premature beats, the sinoatrial node rhythm is not disturbed. The impulse that is arising from the ventricle would neutralize the impulse coming from the sinoatrial node without disturbing the rhythm of sinoatrial node. So the sinoatrial node continues its activity without any disturbance. So these are the main differences regarding compensation between the ventricular and atrial premature beats. So how to know whether the compensatory pause is complete or not? So if we mark the regular R wave intervals on the ECG, then here we can see the abnormal beat R wave appearing before the actual time interval, and the P wave is inverted here preceding the QRS complex. So these features suggest that it is an atrial premature beat and there is a compensatory pause, and the next sinus beat what is shown in the ECG, the R wave of that beat is actually appearing prior to the regular time interval. So if this is the scenario, then it is considered as an incomplete premature beat. So if it is a complete premature beat, then the R wave of the sinus beat that is appearing after the premature beat would be appearing at the regular time interval, indicating that it is a complete compensation. The other way of calculating whether it is complete compensation or not is, if the RR interval surrounding the premature beat is equal to twice the normal RR interval, then it is considered as a complete compensatory pause. I have clearly shown in the picture, if x plus y is equal to twice the z RR interval, then it is a complete compensatory pause. Otherwise, it is incomplete. So the main differences between the atrial and ventricular premature beats will be the shape of QRS complex. So narrow QRS complex, and it is preceded by a P wave, then it would be an atrial premature beat. QRS complexes are wide and there is no P wave preceding the QRS complex, with inverted T wave following the QRS complex is suggestive of ventricular premature beats. Then compensatory pause, again complete and incomplete between atrial and ventricular premature beats. Then the presence or absence of P wave. So these three are the important distinguishing features between the two types of premature beats. So let us look into this algorithm at the end of these tachyarrhythmias to remember how to go about the diagnosis. Heart rate more than 100 is tachycardia. So then when we take a 12-lead ECG, we have to look into the QRS complexes. If the complexes are narrow, that is less than 120 milliseconds, the next step is to see whether the rhythm is regular or not. If it is an irregular rhythm with narrow QRS complex, it would be atrial flutter, fibrillation, atrial tachycardia, multifocal, or it can be sinus tachycardia with premature atrial contractions. If the QRS complexes are narrow, rhythm is regular, then you have to look for P waves. If P waves are not clearly seen, then think of SVTs, as we saw all this while. And if we are thinking of SVTs, then go ahead and treat the arrhythmia with vagal maneuvers or IV adenosine. So as I told you, if the SVT is getting terminated with these vagal maneuvers, most commonly it will be AVRT or AVNRT. If it is not getting terminated, then probably it would be junctional tachycardia or flutter wave pattern. If P waves are seen, then I said mainly in case of SVTs, we have to take into consideration the RP interval. So if the RP interval is shorter, that is less than 50% of RR interval, mainly it would be typical AV NRT or orthodromic AVRT. If it is a longer RP interval, the clear-cut diagnosis of this would be AVRT, and orthodromic is the most common type. Then, on the other hand, if the QRS complexes are wide, then again look at the rhythm, whether it is regular or irregular. If it is regular with wide QRS complexes, then it would be ventricular tachycardia monomorphic or SVT with aberrancy. If it is irregular rhythm, then it would be ventricular fibrillation or polymorphic ventricular tachycardia. So coming to the algorithm which tells about the treatment. So the initial part would be assessment, taking care of the airway, breathing and circulation of the individuals. Administer 100% oxygen, 12-lead ECGs are taken, and meanwhile we have to see if the patient is stable or unstable. If the patient is unstable, then immediately we have to get ready for synchronized cardioversion with early securing of IV access, sedate the patient and go ahead with synchronized cardioversion. If the patient is stable, then we have to again go for interpretation of ECG with the QRS complexes. So if it is a narrow QRS complex and regular, then treating with vagal maneuvers or adenosine 6 milligrams rapid IV push. followed by 12 milligrams. If not getting converted, we may repeat another dose of 12 milligrams of adenosine. If not, then we have to proceed for cardioversion or radiofrequency ablation in later days. So again, in case of wide QRS complexes, I mentioned if it is a regular wide QRS complex, then it would be ventricular tachycardia. Treating with anti-arrhythmic agents, mainly amiodarone, would be more apt in this situation. If it is irregular with wide QRS complexes, then considering defibrillation, especially when it is polymorphic ventricular tachycardia or pulseless monomorphic ventricular tachycardia or ventricular fibrillation. Whatever said and done, we should never forget the 5 H's and T's while treating these tachyarrhythmias. Unless the triggering factor is tackled, the treatment for these tachyarrhythmias will not be complete. So take home message, arrhythmias are real medical urgencies than emergencies. The very essence of management of arrhythmias is early recognition of the cause and correcting it. Never forget the cause, including pain, fever, anxiety, dyselectrolytemia, which we most commonly encounter in the perioperative period. Any abnormal cardiac rhythm will be a forerunner of ventricular tachycardia, fibrillation, and cardiac arrest. So, rate control is more important than rhythm control to improve ventricular filling. Radiofrequency ablation would be the definitive treatment for resistant dysarrhythmias. Quick interpretation and timely treatment of abnormal cardiac rhythm avoids cardiac arrest. Thank you.
Thank you, Dr. Bindu Madam, for your wonderful presentation. You started with the case scenario and you included all specified animations, you making it not to cause any tachycardia to the participants in understanding these tachyarrhythmias. And you made it so simplified by giving a tabulation of all the arrhythmias and their treatment for the, and including the causes and when to intervene and when not to intervene. You made it so simple and more understandable, so calm and quiet, and we didn't realize that the time is almost 7:45 now. So anyway, we're coming to the end of all the sessions, and so can we take the questions, sir?
Sir, moderator, sir, the two questions are there.
Yes, sir.
In the chat. That is intraoperative lead placement during surgery done on chest. Will it have any impact on interpretation?
Will Sudeshna able to answer this?
Yeah, moderator can assign to any of the faculty or moderator can answer.
Yes, sir.
Either you are.
If Sudeshna is leaving me to answer, then yeah, Sudeshna, please.
So I think it can affect the ECG interpretation because of the ECG lead misplacement in case of inaccessibility due to surgical field constraints. I feel it can lead to changes like axis deviation, changes in morphology, and changes in amplitude and inversion of waves. So I think we should always take into account that it's a non-standard placement. So rather than diagnosing MI or axis abnormalities, I think it's better to use it for just rhythm, rate, and trend monitoring, and to go for a repeat post-op standard 12-lead ECG if any significant changes are noted during surgery. So.
No, I think that is the reason why he has asked the second question. See, the lead placed in other than conventional places due to surgical field. How will it interfere in interpretation?
So,
I think the seniors can take up the question. See, he felt troubled.
No, sir, when you place your leads other than the conventional things, you need to have one idea that not only the speed, even the amplitude of the wave is abnormal. Then the direction of your waveform is abnormal. Then, but it will definitely give you some pathology in that. When you have that some pathology, see what practice what would is most of the times is this: look at any pathology in the monitor in the intraoperatively. Most of the times you neglect it as one of the artifacts that's supposed to be avoided in our. You have to add quickly and make sure that you get a good ECG if possible. in whatever position. For example, in the spine surgeries, where the patient is in prone position, you place your leads at the back of the patient rather than on the chest. So in those conditions, whenever you see a minimal changes in normal rhythm, that time you can definitely go and get one regular ECG if possible to rule out any complications. So
Yeah,
that's
that
it.
is right. But to put it in my way, because we have to answer the question straight. See, he has mentioned the chest surgeries and the chest leads. I don't think that there will be any problem because right arm, left arm, and the left leg leads are placed away from the surgical field because he has not mentioned any type of surgery. Mostly, if it is a sternotomy or middle of the chest, it is going to be in the infraclavicular area. So I don't think that it is going to produce any significant change. Only during this diathermy, that artifacts may be there. And he has asked the next question, how if the unconventional leads are placed, like if there is a chest surgery, if you are placing the leads on the back of the chest, see, the simple thing, we have to see not the standard ECG, we have to see the fluctuations in ECG. So even if there is a variation, you take it as a standard ECG before procedure because you are seeing that. And in due course during surgery, if it varies, then it will lead to the rhythm disturbance. At that time, you can verify. That is the reason why in CVP also we say it is not the actual number that matters. It is only the fluctuation in the number that matters. So that is applicable for ECGs also because they are not going to produce any significant change as we expect. Because even if the leads are placed on the back of the chest, like right arm, left leg, that is not going to produce any change because it is only the conduction, probably as moderator mentioned, the amplitude may vary. That is the only thing. Then how many VPCs, one question, sir, how many VPCs intraoperatively is considered abnormal on table management, please?
Sir, VPCs of more than 5 per minute is
That is
considered
right.
to be more significant in the intraoperative period, which warns that it needs to be attended and treated to maintain hemodynamic stability.
So
That is the
it is as
straightforward
a
answer.
PG, as straightforward answer. As a PG, they will ask the exam because I love this question. When you will treat these PVCs, that is ectopics. We at that time we used to call it as ectopics. So when the ectopics is to be treated, 5 points they will say. One, ectopics more than 5 per minute. Then concordant ectopics. Then that is 2 ectopics in a row. Then the multifocal ectopics, that is from multifocal areas it is coming. And the fourth is R and T phenomena. And the number 5 is ventricular tachycardia. Ventricular tachycardia, we take it as ectopics only. So these 5, I think for Dr. Lavanya, we are answering extra. These 5 places, as Dr. Bindu pointed out, it is more than 5 per minute. Then consecutive concordant ectopics, multifocal ectopics, R&T phenomena, and ventricular tachycardia. I think that is a straightforward answer. There is no more questions, sir. So, Dr. Bhaskar, sir, if you want to say anything in wind-up discussion, you can say.
So mainly for the bradyarrhythmias, we see that most of the times the grade 1, grade 2 we treat with atropine or other things. But for the complete heart block, we don't have to go for the pacemaker. Anything else you want to add, Dr. Madhu, regarding this, where we don't have the availability of the pacemaker as such and intraoperatively. So suddenly if the patient goes into complete heart block, what else can we think on?
Dr. Madhu?
Actually, as I mentioned, if definitely not all the setups will be having, equipments to do transvenous or cutaneous pacing. So that time we should we should first follow the American Heart Association bradycardia algorithm. We have to, if it is not responding to atropine, then adrenaline infusion we can start, or dopamine infusion. if not responding, then definitely the possible cause should be treated first, whatever the causes I mentioned. Then if it is causing hemodynamic compromise or going on to any other the malignant dysrhythmia or asystole, then we have to treat like a complete cardiac arrest. Sir, anything to add on from your side if I am leaving something important?
Yeah, I think we can even consider most of the cardiac centers, they have this injection isoprenaline, which can be a
I told you,
life-saving tool.
I mentioned it. Yes, sir, I mentioned it, isoprenaline.
That's, I
Other
think
than
that's
that, anything else?
only drug which is more, we have seen beneficial in complete heart blocks until we arrange whether it's a temporary or permanent. Will take longer time to analyze, and
Yes, sir.
before that, I think isoprenaline will do the better job compared
Yeah,
to other.
it is one of the important question from the examiner side. What is the pharmacological pacemaker? They ask. So isoprenaline is
See,
the
it's,
answer.
again, the routine answer will be atropine, arciprenaline, salbutamol, dopamine, isoprenaline. And see, we have to add by nebulization also, you can give the drugs. That is, beta 2 agonist has to be tried. And that is the reason why slowly all anesthetists to instruct their institutions to buy this AED with that external pacing. Slowly it will come. As you say, so majority of the centers will not have, and suddenly we will get stuck with the complete heart block. Then it is our fate.
Not many questions from the participants. It shows that they understood the subject well.
They have correct. They are very clear, sir. They are very clear. They are very good with the animations also. They have done all these examples they have put, and once it is projected in a YouTube recording, still more views will be there. And if there are nothing more to add, I can request Dr. Hema, our treasurer, to propose vote of thanks.
Before
sir.
that,
Good
I would like to thank you for giving us the opportunity, and it was our pleasure to be on this
Madam,
platform, sir.
we have to thank, madam, we have to thank all four of you because it is a very good explanation about the ECGs, and that is the reason why we are requesting our treasurer to propose vote of thanks.
Good evening, everyone. I thank you all for your participation in today's episode on interpretation of ECG. I thank our academic chairman, Dr. A.L. sir, for guiding us throughout the series. I thank the Department of Anesthesiology, Bangalore Medical College and Institute. Sir, you have made the online class on ECG very interesting.